This is part 2 of chapter 7, microscopic evaluation. We were talking about doing the microscopic. Typically, this is going to be done on a bright field microscope, and that's what we're using in lab. We already talked about the low power field and what we observed, so now we're going to talk about on high power. There's a lot of things that we're going to look at on the high power field. So we're going to start with red blood cells. Red blood cells, as you remember, are very small. They're only about 8 micrometers in length or round. Normal would be 0 to 5 per high power field. Usually what you're going to do is you're going to take an average of what you count in 10 fields. Remember, red blood cells do not have a nucleus. They are refractile. They have that central pallor. They can be visible from any direction. So whether they're top, on the side, rolled, you should be able to see them in any direction. They can be crenated if they're in a hypertonic solution. So these down in B, you can see those are crenated cells. They can be mistaken sometimes for white cells because they have almost that granular looking appearance, but you'll notice they're jaggedy. See those jagged edges? Whereas these are normal, okay? I think I probably could put that in a different color. But this one over here shows these are reds. And these are white. If you just kind of want to see the difference in size too, so that kind of help you out a little bit. They can swell, which can also cause them to lyse in a hypotonic, which means that if they're lysing, they're breaking open. It can be also in a diluted or an alkaline where it would swell. And when that happens, you can have what are called ghost cells. When you have a ghost cell, all that's left is the shell, and that's all you'll see. And the appearance is normally seen in a urine with a low pH. If you recall what cells look like on a hemocytometer or when you did a wet prep, we talked about those in body fluids and hematology, and we'll talk about them a little bit more this semester too, but that's what they look like. So it's a good thing to compare them to because those were unstained cells as well. Hematuria, this is where an excess amount of red blood cells can be seen. When you have blood seen on your chemical analysis on the reagent strips, you may or may not see red cells, okay? If you see the red cells under your microscopic, this is called hematuria. Now, you could also have hemoglobinuria, which is where the red blood cells have lysed. So when we're talking about what you see on your chemistry or your chemical analysis doesn't match what's on your microscopic, just know that with the blood, it may or may not be there. So just in case, if they've hemolyzed, you're not going to see them, and that's hemoglobinuria. And doing a microscopic examination is how you would determine the difference between the two. So like I said, hematuria is where you have a lot of red cells that are going to be present or just present in general. But if you have an increased number of them, they're typically going to be associated with glomerular damage. When you have a whole lot of red blood cells, you may also see some red blood cell casts. If you have the red cells, the red cell casts, and protein, then this can indicate renal, glomerular, or tubular bleeding. And then if you have the RBCs but no casts and no protein, those can indicate a lower bleed. We'll talk in Module 3 about diseases in more detail, but this is kind of getting you started for that, okay? There are some things that are red blood cell lookalikes. You have yeast, which is this first one on the left. Yeast can kind of look like red blood cells when they are by themselves, okay? So they're round and they I don't know, they can vary in size, but a lot of times they'll be big whenever they're not budding. Budding is when they're touching each other, uh, like most all of these in here are. This is budding. See how it's got the small top and the large bottom? That's called a budding yeast. You also have ones that have hyphae. This might look like it's becoming one, but there's not a good picture of this in here. There's some in your book, but with yeast you would put which one it is, if it's budding or if it had the hyphae. But red blood cells kind of can look like yeast when they are by themselves, kind of like this one. This one is not budding. Air bubbles. Their air bubbles are highly refractile, so it's round in shape. There's no there's no nucleus. There's also no central power. It's all uniform throughout. It looks exactly the same. So that's how you can tell it's a air bubble. You have oil droplets, which they also look a lot like air bubbles. And they're also highly refractile. So both the air bubble and the oil droplets look the same. You can also have, we haven't looked at crystals yet, but you can have calcium oxalate crystals that can look like red blood cells. But in a case like that, you may probably also be seeing some calcium oxalate crystals in a different type of shape. Crystals can take on more than one shape. So when you start studying for those, you need to know different ways that they can look. Sometimes people mistake them for white blood cells also. Remember, your white blood cells are larger, but if you cannot tell the difference, you can use acetic acid, and your acetic acid is going to lyse the red blood cells. Because sometimes you'll have a large amount of cells. So if you have a lot of them, that can be a good way for you to get rid of red blood cells. Also, if you're trying to count the white and see how many you have, and that'll help the nuclei of the white blood cell to be accentuated. And these are our white blood cells. So like I said, a lot of times they may get mistaken for being red blood cells, but they are kind of grainy looking. So that's one way to help you out. Most of the white blood cells that you're going to see are going to be neutrophils. That's not all of them are going to be, but most of them are neutrophils. And that's because you usually are going to see white blood cells due to some type of an infection. So, and that all makes sense if you go back and you think about your white blood cells and the role of each different type. So neutrophils are your most common because of infection. They are larger than the red blood cells. They're about 10 to 14 micrometers. 0 to 5 on high parafield is also normal. So just like on your red cells, you can see a couple of them and it still be okay. But usually, once again, you're going to take those 10 fields and average. They're similar to the size of a nucleus of squamous epithelial cells. Remember, we looked at that already. They're spherical, so they're going to be that circular shape with cytoplasma, granules, and the nuclei segments. So on these down here, my drawing thing keeps going away. These down here, you can see the nucleus. Now it looks like a smiley face, but it's kind of segmented. They can clump in acute inflammation. So these down here are starting to kind of clump. They're pretty friendly, but they'll be in a tighter formation. That's why I said when you talk about casts, remember if you call white blood cell casts, it's clinically significant. So you're making sure it's not actually just a bunch of white cells touching. So like you can see, these are just touching, but this isn't a good clump picture, but you'll see clumps when we're in lab. They can disintegrate as they age. So go back and looking at refrigeration and stability of urines from the first part, module 1, I think, and you'll be able to see how things change. So just your changing of pH of the or any of it, but pH plays a really big part of it. But any type of improper storage is going to cause problems with everything, microscopic and chemical wise. Okay, well, almost everything. Um, they'll swell or lyse in a hypotonic solution, and then they'll get smaller in a hypertonic. So in one that's a hypertonic, because they're smaller, it could really be easy to mistake those for red blood cells. But once again, you're going back and you're looking at the chemical strip, what you got for those results, and does it match what you're seeing under the scope? This is another good picture of them. Oh, this one on the bottom is real clumped. So it's a really thick field of them. And that would be really positive on your chem strip too. This also looks like when you did a body fluid under the hemocytometer also. So they look exactly the same. This is just what unstained cells look like. Leukocyturia or pyuria, these are with white blood cells being present and seen. A lot of times when you have leukocytes that are going to be, or yeah, leukocytes that are seen, it's with a UTI. And depending on whether or not there's cast would depend on if it was upper or lower. Typically, if you have a whole lot of leukocytes, it's going to cause it to be a cloudy urine and it's going to stink, and that's because there's infection. It can also be seen in some renal diseases and inflammation. There are also some white blood cell lookalikes. Remember I said that your renal tubular epithelials, when they're small, when your RTEs are small, not when your white blood cells, but your RTEs when they're small. Let me go back up here and see if I can find one. What number is this? See how they're real round and they're kind of granular over here too? That's why they're easy to mistake as being white blood cells. So especially when they're really small. We can mistake them for being red blood cells. Remember I said that you can use acetic acid and that lyses your red blood cells. So if you needed to do that. There's other leukocytes in the sediment. Remember, mostly we have neutrophils, but you can also see what are called glitter cells. These are found in hypotonic urine. And all it is they're swelling. The cells are going to swell and then they kind of sparkle. They're non-pathogenic, so there's nothing significant about them. You can also see eosinophils or other mononuclear type cells. All right, crystals. So crystals are pretty, but we also don't really want to see a whole lot of them. Some of them are pathological and some of them are not. What they are is they're precipitated solutes, and sometimes they're going to form as urine pools. We base them primarily on shape, solubility, and pH. So whenever you do your study tools, that's kind of the best way probably to go about classifying them. Maybe start with pH, because depending on what the pH is it acidic or is it alkaline? Is it normal? Depending on which of the three will depend on what crystals can be seen. And when we talk about certain diseases later, pH plays a role in that also. Then you want to go with their shape would probably be the next one I would say to look at, because they all have a different type shape, and then solubility being the third. And there's other ways you can ID them, but those are your three normal ones. They can cause tubular damage. So like I said, some of them are pathological, some are not. There's different things that can contribute to their formation. Any type of a change in temperature can also cause crystals. So we'll look at those in a minute. That's important to know too, that they may not have been anything there, but then you change the temperature and it causes crystals. So things like temperature, pH, remember they're pH dependent. If you're on meds or have some kind of weird diet, then those can also cause certain crystals. Or if you have stagnant urine flow, that can also. It doesn't matter what kind of crystal you have, whether it's pathological or not, you always call it. So whenever you report, you're reporting all crystals as either few, moderate, or many, and they are seen on high power field. So that's how you're classifying. If you see one on low power, okay, that's fantastic, but we don't call them on low power. We make sure we call them on high power, okay? And we'll talk more about this when we're in the labs also. You have a chart that you're supposed to go by that shows you how to classify each thing. So you always make sure that you refer back to that. The first way we're going to classify them, we're going to look at the pH. So with acidic, there's not that many of them. So acidic urines are usually going to have urate crystals. Calcium oxalate can be found in both. Okay, calcium oxalate is very normal. Anything that's alkaline is typically going to have a pH that's greater than 7. And these are the more common ones that we'll find, and they break down into other type of crystals. So biurate, carbonate, and phosphates. They're different types of crystals. They have other names that go with them too. But anyway, so you need to be able to differentiate which one can be found in acidic, which can be found in alkaline. Amorphous, the one on the left is acidic and the other one is an alkaline urines. Okay, that didn't split up like it was supposed to either. This is something that is when we refrigerate them. Typically, we will get amorphous crystals whenever we refrigerate, and then we take it out. Anything that looks like it's settled on the bottom, and you'll notice when you take out the refrigerator, it looks like it's got nasty stuff on the bottom of it. And then you'll mix it all up to do your analysis. And then when you spin it down, because all that stuff was floating, it's going to be in the bottom, and typically that's going to be amorphous. It's not significant. Okay, you do ID it, and we ID it based on the pH. So if you have an acidic urine, it's called amorphous urates. And these can be kind of a pinkish colored granule. But anyway, that make sure you get the two different, what they're each called, sorry. If it's in an alkaline urine, they're called amorphous phosphates. So urates for the acid, phosphates for the basic, which is your alkaline. Your amorphous phosphates, they have granules that kind of appear to be more of a white color, and they look a lot like bacteria. And also over here, they look kind of like yeast. It's not big enough. Okay, so they're real small. That's why we say it looks kind of like bacteria. These are calcium oxalate on the left. They can be found, remember, at any pH, so they're very normal. Most of the time, they're going to be this boxy shape, kind of an envelope. But this round looking one right here, that is also calcium oxalate crystal. So you need to go in and, like I said, you need to be able to identify them in different shapes. So they can be found in more than one shape. You need to be able to identify a calcium oxalate crystal if I give you a picture and it has either one of those. So you need to be able to identify shapes. So like I said, that's why I said when we talk about classification, typically start with the pH, then the shape, then the solubility. Uric acid crystals, these are also found in acidic. They're kind of overlapped. They're kind of a diamond shape. So these are overlapping, but you can kind of see how they're diamond shaped. They have that, they're usually kind of round on the sides, but that's the type of shape that they take. And they're not always going to be overlapping like that. These uric acid are, like I said, they're in acidic. Sorry, lost my train of thought. So these are your triple phosphate on the left. Triple phosphate are also normally referred to as coffin lids. So they kind of look like coffins. The ones on the right are ammonium burate. And that's these right here that are kind of spiky. And they look like a thorny apple because they've got all these thorns that come off of them. These are the crystals that are normal on the top and the abnormal on the bottom. These are classified only in this chart by what's normal, what's abnormal. They don't have anything to do with the type of pH they're found in or anything like that. These are just so that you can see them. They have different shapes, like I said, so you need to be able to look at more than one. These are kind of some common ones. When we start talking about these abnormal ones later, look how spiky all of them are. A lot of them are spiky. So that'll kind of point you in that direction. These calcium phosphate, they look spiky, but they have all these blunt edges. So typically you see something like this that looks like a bunch of needles. You're looking at something that's abnormal. Just a heads up on that one. These are some of your abnormal crystals found in acidic or neutral urines. Remember I said we need to know if they're which one they're in. I'm not going to read them all off because you can see them. And once again, they were in this chart. So this is just most of them again. And some of them do have color in them. Like on these, the bilirubin, look how yellow they are, which would make sense with them having that. Sulfa is kind of a yellow color anyway, so that kind of makes sense. Crystals are weird. Our cholesterol is weird. They look just kind of like little boxes everywhere. The cysteine does too. These leucine are probably kind of difficult. We're not going to see any in lab. You may see one on a test or a question about it, but you will not see this on any of the urines that you do. And so you don't even have to worry about if you can't identify the difference between that and a white blood cell, because you're not going to see it. You probably just have, when we do diseases, you'll need to be able to know what that goes with. Or if I give you a list and say, if I had an acidic urine, then which one of these can be found? Or which abnormal crystal is found in an acidic urine? Well, you need to know the difference between normal and abnormal crystals also, right? So that can kind of help you to limit, but you won't see these in lab, not in any type of a urine. If we have a slide or something, that's different, but you will not have to identify them in any of the urines that we get because we'll have so many that are normal. We're not going to talk about liver disease on your test or any of the other diseases, okay? You don't have to know about it or a bunch of things, how to identify it, but anything I have talked about disease-wise that goes in here, you do need to know like which cell, okay? So like with liver disease, when we talk about crystals, these are the 3 types of crystals that you'll see in liver disease. So that's where we're going with the abnormal crystals. So just kind of know that these go with that, but you don't have to know what liver disease is and how to diagnose it and all that stuff. So when you go back, like I said, and you do your study tools, make sure you know on your crystals what pH they're found at, what shapes they're in, and whether they're pathological or non-pathological.